Cardiovascular system infection. Infection of the heart. Infection of the endocardium layer called infective endocarditis, myocardium layer called myocarditis, and pericardium called pericarditis. Excess fluid in pericardial cavity called pericardial effusion. Infection of blood vessel called mycotic aneurysm, infective endocarditis, and autoimmune mediated like the acute rheumatic fever. Now about infective endocarditis. Microbial invasion of heart wall result in formation of bulky friable vegetation composed of mass of platelets, fibrin, microcolonies of organisms, and anti-inflammatory cells. Now the classification of infective endocarditis: two subdivision, acute and subacute. Evolution rapid, then in slow. Involves normal cardiac valve in acute and previously damaged heart walls in the subacute. Effect: substantial morbidity and mortality even with appropriate therapy. And then subacute follow a gradual progressive course of weeks to months. Most patients recover. Commonly, less common type account for 10 to 25% of all cases. More common type 50 to 60% of all cases. Pathogenesis. Sequential steps include predisposing factor like underlying cardiac defects and use of IV catheter. It causes endothelial injury, which causes colonization, and this causes formation of vegetation, and this causes metastasis. Endothelial injury in this favor deposition of platelets and fibrin thrombus formation. During colonization, during transient bacteremia, example after brushing teeth, the bacteria adhere to thrombus, and the formation of vegetation in this further deposition of platelets, fibrin, and inflammatory cells occur surrounding entrapped organisms to produce vegetation. Metastasis means resulting vegetation ultimately seed bacteria into blood at slow but constant rate, which can metastasis. Etiological agents of infective endocarditis: Staphylococcus aureus, Coagulus negative staphylococci, Streptococci, Enterococci, and Pneumococcus. Clinical manifestation: both cardiac and non-cardiac manifestation. Non-cardiac manifestation include appearance of new worsen regurgitant murmur, which is more useful for diagnosis of IE involving normal wall. Non-cardiac manifestation include fever, chills and sweat, anorexia, weight loss, arterial emboly, splenomegaly, neurological manifestation. Diagnosis: modified Duke criteria include major criteria and minor criteria. Major criteria include positive blood culture, evidence of endocardial involvement of any burn, positive echocardiogram, or new valvular regurgitation. And the minor criteria include predisposition, fever, vascular phenomena, immunology phenomena, and microbiological evidence. Definitive carditis if following are present: two major criteria, or one major and three minor, or five minor criteria. Now the blood culture. Causative microorganisms isolate from blood culture should be collected before antibiotic therapy. Two blood cultures had collected within more than 12-hour interval, or alternatively 3 or more collected over more than 1 hour. Example: 30-minute gap between first and second, 30-minute between second and third. Collected from manufacturer site, then divided into 2 bottles. Consider as positive when 1 bottle is positive. Non-blood culture test includes: serologic test can be used to implicate some organisms that are difficult to recover by blood culture. Example: Brucella, Bartonella, and Coxiella pruneti. Isolation of pathogen in vegetation. Microscopic examination with special stains.